Welcome to the Virtual Lung Cancer Summit sponsored by Johns Hopkins University School of Medicine and Oncology Care Live. My name is Dr. David Ettinger, Alex Grass Professor of Oncology at Johns Hopkins, and you are tuned into a live session called Moving Biomarker Identification into Clinical Practice with Heather Wakelee. This session kicks off our 2013 Lung Cancer Summit, Improving Patient Outcomes Through Earlier and More Personalized Treatment of Lung Cancer. I am excited to chair this program again and bring you sessions on biomarkers, screening, and targeted therapy for non-small cell lung cancer. Today's program will feature respected faculty from Johns Hopkins University School of Medicine, Stanford University School of Medicine, and Sloan Kettering Cancer Center in New York. Dr. Wakelee is a clinical investigator with a focus in lung cancer and other thoracic malignancies. Along with her other colleagues in thoracic medical oncology at Stanford, she is focused on clinical trials with agents that are specifically targeted to known mutations in lung cancer. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send us questions anytime during the program through the box in the lower left-hand side of your screen.
Thank you. So I'm going to be talking about moving biomarker identification into clinical practice. First, I start with this slide from the ECOG 1594 trial, which just showed where we used to be. Patients would get first-line chemotherapy, and there was really no difference and no way to select what that chemotherapy should be. Histology didn't matter, and we saw a lot of non-small cell lung cancer NOS. Bevacizumab then was developed, and for the first time there was a differential whereby toxicity was different by histology. And so that was the first time we started paying more attention to histology and not just talking about all non-small cell. Then came pemetrexed, where we actually had an efficacy difference by histology, where this drug worked better in non-squamous patients. So to go into that a little bit more detail, these are some of the common immunohistochemical markers that we can use to distinguish adenocarcinoma from squamous cell carcinoma. So with adenocarcinoma, the best marker is still TTF1. There's some others, napsin, PE10, some stains for mucin. With the squamous cell carcinoma, P63 and P40 are really some of the better markers that we have. CK56 and some others are also available. So many times the pathologist can tell just by looking, but when that's not obvious, these immunohistochemical markers can really help us figure out if we're dealing with an adeno versus a squamous. So I'm going to talk a little bit about anti-angiogenesis because that was the first realm where the histology difference really seemed to matter. So to remind everyone, in order for a small group of cells to become a larger tumor, you need to have angiogenesis, and VEGF plays a key role here. When bevacizumab, which is an antibody to VEGF, was being developed in lung cancer, the first larger trial was a randomized phase 2, and in that trial of just under 100 patients, there were actually 6 life-threatening pulmonary hemorrhages. 4 of these events were fatal, and this of course got everyone's attention. In further evaluations, it seemed to be that most of these hemorrhages were occurring in patients with squamous cell histology. So 4 of the 13 patients who had squamous cell histology had a hemorrhage. So that was 30% versus only 4% of those with adenocarcinoma. And after this analysis was done, further trials of bevacizumab in lung cancer have been restricted to non-squamous histology.
Heather, a question came up about histology. Which type of lung cancers can be detected easily? Do you rely just on the histochemical type, or do you rely just on the immunohistochemical stains?
Well, I think sometimes for the pathologist, the cells that are, especially the ones that are more differentiated, there are specific characteristics where they can tell the difference between a squamous cell versus an adenocarcinoma. It could be that there's mucin where it would be an adenocarcinoma. They might see bridging with the squamous. So when that's there, it's not as big of a question. But when you can't tell, if it's a little bit less differentiated, that's where the immunohistochemistry can really play a role.
Very good.
Right. So with bevacizumab in advanced lung cancer, we've now had a couple of big phase 3 trials. And in both of these trials, there was a big improvement in response and progression-free survival. But in only one was there an overall survival benefit, and that, of course, was the ECOG 4599. And it was this inability to see a survival benefit in both of the large trials that got us wondering if maybe we should be doing more to select other than just looking at histology. There are also a lot of molecules in development that are not just targeting VEGF itself, like bevacizumab, but the VEGF receptor. And so there are many, many small molecule tyrosine kinase inhibitors, some of which are already approved to treat other cancers, but none of which have a label for non-small cell lung cancer. And in the trials to date with the VEGFR TKIs, none of them have actually been able to show an improved survival when added to chemotherapy. And single agent activity has been seen, but none that's been validated in a randomized phase 3 trial. So we have bevacizumab, which increases response or progression-free survival when added to non-squamous non-small cell lung cancer, but it only improved overall survival in 1 of 2 trials. We've had some disappointing results with the VEGFR TKIs, and we really need a better way to select patients to get these drugs. So there are predictive and prognostic markers in development to help us guide this patient selection, but none have been validated. And some of these are ICAM, VEGF levels, VEGF polymorphisms. And on the next slide, I talk a little bit more about that. So these are the biomarkers for anti-angiogenic therapy. There's been a lot of work looking at hypertension. And it seems that there's a correlation. If patients develop hypertension, they seem to have a better benefit. But a marker that you can only figure out after the patient started drug is not ideal. There's been a lot of work looking at ICAM and VEGF-A levels, but those seem to be more prognostic and not really predictive of benefit. The VEGF polymorphisms, there's been a lot of work there. There's some promise. Maybe these are going to end up being predictive, but different studies have found different polymorphisms to be important, so I'm not sure we've definitely found the truth there yet. There's been some work looking at a variety of cytokines and angiogenic factors. IL-6 is perhaps one that we can be looking at, but again, nothing that's been proven. So we're still in need of truly predictive biomarkers to help us move forward in anti-angiogenic therapy. And so to date, histology is really the only good biomarker, and it's more of a biomarker of patients who shouldn't get the drug as opposed to who should get the drug. So with that, I'm going to move on and talk about chemotherapy.
But let me ask you a question. Does it make a difference? The feeling was in the phase 2 study that squamous cell, is it the squamous cell or is it the cavitary lesions?
So it's hard to distinguish between. We know that patients who have cavitary lesions are the ones most likely to bleed. And there's definitely a correlation between having a squamous tumor, especially one that's larger or more centralized. They actually have a very good response to the drugs, and that's why they cavitate and tend to bleed. Very few patients have cavitary lesions going in, and so it's hard to know who's going to develop the cavitary lesions other than that squamous risk. But there's been a lot of work with trials trying to figure out how we can do this safely for squamous patients. Give the chemo first, give radiation first, and none of those have given us a clear safety signal. They've still had bleeds.
So I saw a patient actually last week with a cavitary adenocarcinoma, bilateral disease. Would you give it in that scenario?
It depends on how large.
Okay. They were small.
They were small. I would probably think about it, but if I see a large cavitary lesion, I don't worry about the histology. Okay. I don't give the drugs. Okay. I've had a couple of patients over the years who have had hemoptysis, and it is not a pleasant thing. So I'm wary. And
one other question. In the NCCN guidelines, we're both members on the panel, we say bevacizumab, if criteria met, bevacizumab plus a doublet.
Yes.
Does it make a difference, do you think?
Oh, David, that's a much bigger question than we have for today. Okay. The approval, of course, is with carboplatin and paclitaxel. And there are some who believe that the taxane and bevacizumab is a better pairing than some other drugs. I'm not convinced of that. I will still think about other doublets, including pemetrexed, and I did a trial actually with gemcitabine and bevacizumab in the past as well. And I think we do see increased activity, especially that response benefit. I don't think that's restricted just to the taxanes. Okay. As far as whether we have a true survival benefit in the unselected patients, I think we don't know that with the other drugs. So that's the cautious answer. All right, so let's move on to the chemo. This slide is looking at the randomized phase 3 of cisplatin gemcitabine versus cisplatin pemetrexed when the pemetrexed was a new drug. And in this, overall, there was no difference between, this looks a lot like that ECOG 1594 slide I showed at the very beginning. However, in a subset analysis, which was pre-planned, when they looked at the patients with non-squamous histology, there's a much bigger separation of the curves. And a survival benefit hazard ratio here is 0.8, statistically significant. And with this information, it looks like pemetrexed really works better in the non-squamous patients. To follow up on that, this is the trial looking at maintenance pemetrexed after other chemotherapy in the first-line setting. So this is a switch maintenance approach. So patients had 4 cycles of a platinum doublet that did not have pemetrexed, and then were randomized 2-to-1 to pemetrexed maintenance or to get a placebo. And in this trial, there's that same histology difference. So on the left, for the non-squamous patients, pemetrexed is clearly better than the placebo, hazard ratio of 0.7, statistically significant. But in the squamous subset, there was no benefit to the pemetrexed over placebo. And so with this information, we now have a restriction where pemetrexed is really not a drug that we think about using in patients with squamous histology. So why is that true? And there are a lot of different theories going into how does pemetrexed work. And pemetrexed works really by inhibiting 3 enzymes, all of which are folate dependent and involved in DNA synthesis. So the thymidylate synthase, dihydrofolate reductase, and GARFT. And there's been a lot of work looking at thymidylate synthase, or TS especially, showing that if you have high levels of TS, patients seem to be less sensitive to pemetrexed. And so there's been work looking at baseline expression of thymidylate synthase and how this correlates with response. And squamous cell carcinoma tends to have higher levels of TS than adenocarcinoma. And so that's the theory as to why there's this histology differential. So on this next slide, this is from a paper by Seppi et al. From 2006. And on the right panel, you see the adenos versus the squamous and the thymidylate synthase levels. And you can see that the squamous patients on average had much higher levels than the patients with adenocarcinoma in the tumor. This is some work that David Gandera presented in 2009 looking at non-small cell lung cancer, adeno versus squamous, and also colorectal cancer, looking at the baseline thymidylate synthase levels. And you can see again here that in the squamous patients at the bottom, the levels were higher than in the adenocarcinoma patients. And when you bring that into the clinical trial setting, there have been a multiple series of trials where patients receiving pemetrexed had their thymidylate synthase levels evaluated and then compared that with outcomes. So this is a publication by Agawa from 2012, from this year, where you've got progression-free and overall survival. And in both of these, the upper curve, the patients doing better, are those with lower thymidylate synthase levels. And the patients who had worse survival, both progression-free and overall, had higher levels. Now this is a retrospective analysis, and these are a trial where all the patients got pemetrexed. So we don't know if this is really predictive versus prognostic, but it's intriguing. And there have been many, many other series which have looked very similar to this. So I wanted to just, at this point, bring up the prognostic versus predictive. That's a very important distinction. Again, reminding everyone that a prognostic marker indicates a survival benefit or detriment regardless of therapy. So we know in lung cancer, larger tumors, a higher stage, those are prognostic markers. A predictive marker is what we really want to find. That's what helps us know of a differential benefit from a particular therapy. And that's what we're really going after. So there are predictive markers that have been studied in non-small cell. And in general with these, lower levels is equal to sensitivity. So we just talked about the pemetrexed and the thymidylate synthase, or TS. ERCC1 has a similar correlation with platinum, RRM1 with gemcitabine, and I'll talk about those in the next couple slides. BRCA1, low levels correlate with platinum sensitivity, but high levels with taxane, so that's something that's being looked at, especially by the Spanish group. And then we all know about EGFR mutations predicting for response to EGFR tyrosine kinase inhibitors, and the same with the EML4 ALK translocations and crizotinib response. So a little bit more detail about these other enzymes. So ERCC1 is part of the nucleotide excision repair complex, and it's important for platinum-induced DNA adduct repair. So if you have high levels, the cells are better able to repair that platinum damage and are therefore resistant. And if you have low levels, you're more sensitive to the platinum. With RRM1, it's the same idea. This is another gene involved in nucleotide metabolism, and it seems to correlate with gemcitabine efficacy. In that same way, high levels repair the damage, not effective. Low levels, very sensitive. So based on that theory, there's been a lot of work done by Gerald Bepler, who was at Moffitt at the time a lot of this was done, and also George Simon, where they've had patients and they tested their tumors in real time to figure out these RRM1, ERCC1 expression, and then dictated the chemotherapy based on those. So this is their MADE-IT schema. And the original one was a non-randomized study where all patients had the ERCC1 and RRM1 levels evaluated. Those who had low levels of both got a platinum, carboplatin, and gemcitabine. If they had high levels of both, they got neither of those drugs and instead got docetaxel and vinorelbine. And if you had high of one and low of the other, then the cocktail was based on that as well. They do tend to correlate. So usually if you have low levels of ERCC1, you also have low RRM1 and vice versa, but not always. That study looked very encouraging, so they've just completed a randomized phase 3 trial where patients either got standard chemo, which was the carboplatin gemcitabine, regardless of these levels, or had their chemotherapy dictated by the levels. And that has not yet been presented, so we'll wait and see those results. But there was a similar study done by the Spanish group a few years back. The difference here was their control arm, everybody got cisplatin docetaxel, so different chemo. And in their experimental arm, if you had high ERCC1, you got gemcitabine and vinorelbine. If you had low levels, you got cisplatin docetaxel. So for low levels, it was the same chemo as if you were on the control arm. They were able to do this testing for most of their patients, but about a third they weren't able to get the levels looked at. And these are the results from that study, which was published in the JCO in 2007, so a few years back. And what they showed was that there was an improvement in response. So if you look at the control, the response rate was about 40%. In the custom arm, it was about 50%. But that did not translate into a meaningful progression-free or overall survival benefit. So it was not a definitive win for this approach. There's also been a lot of work looking at ERCC1 and RRM1, especially ERCC1, in adjuvant chemotherapy. So this was a study from the YALT adjuvant trial, which was, of course, the largest adjuvant trial to date. And in this study, they had about half the patients were able to get their tumors tested for ERCC1. And when they drew the line of what's a negative versus a positive or high-low, it was about 50-50. A little bit more than half the patients had these sort of lower ERCC1 levels, and about 44% had the higher or positive. And what does that mean for patients? Well, if you look on this slide, the patients who had the ERCC1, what they called negative, which are really the lower levels, they seem to have a better benefit from the chemo. So the hazard ratio for overall survival in the final analysis was 0.76, which was statistically significant at 0.76. But for patients who had high ERCC1, where you would have predicted that they wouldn't have benefited from the chemo, they didn't seem to. Hazard ratio there was actually 1.2. And so this is very intriguing, but again, it was a post hoc analysis on a subset of patients, but it has led to these studies. So there are a lot of ongoing trials trying to validate this result. The Southwest Oncology Group did one that was more of a proof of principle, where they were able to show that they could look at ERCC1 and RRM1 in real time to help guide treatment. And then there are ongoing trials in Europe where all of these have a control arm of patients getting the adjuvant chemo versus an experimental arm where that adjuvant treatment is dictated by ERCC1. Some of them are also looking at thymidylate synthase. Some are also looking at EGFR mutation. So these are all ongoing and I think will really help us know more about the importance of the ERCC1 especially. Okay, so biomarkers for chemo. Histology is important for chemotherapy selection. Pemetrexed is restricted to non-squamous. The thymidylate synthase levels may correlate with pemetrexed activity or may just be prognostic. ERCC1 may predict for platinum efficacy. RRM1 may predict for gemcitabine efficacy, but the definitive trials are still pending. And I'm personally not using these at this point in my clinical practice.
You never use it?
I don't order it. And if I see it, you know, we talk about it, but I haven't really used it to change my treatment patterns at this time. I know some people do. I just haven't been that convinced by the evidence yet.
So I've used the ERCC1 and TS in adjuvant therapy in patients over the age of 80, 85. I had one 90 to justify whether when the patient wanted the therapy, and I'm questioning it, and they had low expression of ERCC1 and TS, I did it. If it was overexpressed, I was able to convince them that it wasn't worth doing. So in that select population, I've used it. It's not ready for prime time, but it's not been ready for prime time for how many years now?
Well, I mean, again, there are ongoing validation trials, and you know, we'll see how the MADET results come out. But I just, to me, it's not a useful tool yet, and perhaps I'm just being too strict in what I want to see to move forward with it. I know that there are some people who do feel it can be helpful, and there are plenty of ways to get that results back. You know, a lot of companies will do that test. So I also just wanted to mention, sometimes we hear about these chemosensitivity assays, and I believe that those still are a little too early for prime time, still getting validated. Okay, so I'm going to move on and talk about EGFR, epidermal growth factor receptor. This cartoon is really just showing the epidermal growth factor receptor on the cell surface. You need the ligand to bind, dimerize, and then that turns on the tyrosine kinase activity. The drugs that we know as the tyrosine kinase inhibitors, gefitinib, erlotinib, afatinib, those are all working at the tyrosine kinase domain itself, and therefore they're going to work when that domain is turned on no matter why it's turned on, such as in the mutations where it's turned on constitutively. Cetuximab and other antibodies, they're working at the different level. They're working sort of up where the ligand's going to be binding and blocking that binding. And so they're not as active when it's on for some other reason, say in a mutation, but can be helpful in other settings. And so we'll go through that data a little bit more, really focusing on the biomarkers though. So this is the initial phase 3 trial of erlotinib versus placebo, showing that there was a benefit to erlotinib, a 2-month overall survival benefit. But of course this wasn't in all comers. It became clear that certain patients had a bigger benefit, and those patients tended to be non-smokers, were more often women than men. And that led to the big IPASS trial in Asia, where patients who had no or very limited smoking history and adenocarcinoma were randomized to get an EGFR TKI, which in this case was gefitinib, versus chemo up front. And the initial results of that trial were somewhat confusing because there was a crossing of the curves indicating that there might be 2 different patient populations for PFS and no overall survival benefit. But at the time the trial was ongoing, there was a lot of science going on, and we learned about these EGFR mutations and identified the fact that some patients with non-small cell lung cancer have somatic mutations in EGFR which are hyper-responsive to the EGFR TKIs. And there are 2 that are very common. One is this in-frame exon 19 deletion, and another one is the L858R point mutation in exon 21. There are a lot of different ways of looking for these. Sequencing is the most expensive, but one of the clearest ways to do it. And then there's been a lot of assays based around PCR technology to identify these mutations now that we know the ones that are the most common. And if you look at who has these mutations, it's about 10% of all comers with non-small cell lung cancer in the US. It's more common in Asian countries, more likely in an adenocarcinoma histology, more likely in women than men, and especially more likely in non-smokers. So when they went back and looked at the mutations, they found that in this trial in the IPASS, about 60% of the patients had an EGFR mutation. And for those 60%, they did better getting upfront gefitinib, better progression-free survival, which is the curve on the left. But for the patients who didn't have the EGFR mutation, even though clinically they looked the same as the ones with the mutation, they were much better off getting chemotherapy. So this is a really clear predictive biomarker that if you have an EGFR mutation, getting an upfront EGFR TKI is better than chemo, but if you don't, then you should get the chemo. So this is really, really important result.
But this study also showed that if you had the mutation and you got chemotherapy, the response to the chemotherapy was higher.
It was, but it wasn't as high as with the gefitinib. So. So the way I look at this is if I don't know the mutation result, I give them the chemo because that's going to be helpful either way. And they can always get the EGFR TKI later because we don't get a survival benefit with the upfront because there's crossover. Patients eventually get their TKI, they make up the difference. None of the trials have shown us a survival benefit so far. If I know there's a mutation, I start with the EGFR TKI. But if I don't know, I don't feel like I'm harming patients by starting them with chemo.
And the other question is, it's my understanding, speaking to my Chinese colleagues from China, they tell you that squamous cell, the incidence of the EGFR mutation is 10%.
So it's maybe not that high in this country, but it's not zero. Right. I've certainly had some patients who have squamous histology and have an EGFR mutation, and so I still believe we should be testing and looking for it, even in the squamous patients. Perhaps not in the patients with a 100-pack-year smoking history. It's much less likely, but it's a non-zero chance, and since it can really improve treatment if we find this, I think it's worth looking. But that's a matter of debate. You know, there are certain guidelines that say not to, certain guidelines that do, and so.
So the NCCN guidelines, as you will know, in this latest version, version 1 of 2013, said if you have squamous cell carcinoma and you're a never smoker, consider getting the mutation, the EGFR mutation.
Right. Okay. So this is a slide that Dave Gandera had put together, kind of outlining the differences, looking at mutational screening with PCR and sequencing versus looking at gene copy number. So we were really focused on the higher protein expression, the gene copy number, so the protein expression with immunohistochemistry and the copy number with FISH testing to see if there are other ways to screen besides just looking for the mutations. And so I want to talk a little bit more about that. At this point, for the EGFR TKIs, it's all about the mutations. The FISH isn't something that's being routinely done now for EGFR, but still in trials. And then the immunohistochemistry, probably not so useful for the EGFR TKIs, but perhaps for the antibodies. So with that, I'm going to talk a little bit about cetuximab. So when added to chemo in non-small cell, the additional efficacy is moderate. We have the FLEX trial, which was positive for survival, was a plenary to ASCO, but did not lead to FDA approval. The EGFR mutations don't predict for benefit with this drug. This is the overall survival curve showing this about 1 month overall survival benefit. And now I want to talk a little bit more about some expression work that they've been doing, looking at, with immunohistochemistry to see if that can predict for benefit. So the only selection so far with cetuximab had been rash development after first cycle, which again, less useful. If you get a rash, you've already started the drug, so what are you going to do? Stop? Not stop? But when you look at immunohistochemistry, patients who had low protein levels did not seem to benefit with cetuximab, but those with high levels had a hazard ratio of 0.73 for overall survival. And so perhaps this is a way we can select. But again, this was a post hoc analysis. The FDA said that was not adequate, and I don't know that we're going to get a randomized phase 3 to really prove that. I'm now going to switch towards EGFR resistance. I think we'll be hearing more about some of the treatment strategies in this setting in one of the later talks. But T790M is about half of acquired resistance. We know this from trials where patients have had repeat biopsies. They're irreversible EGFR TKIs that seem to have maybe some benefit there, especially with afatinib, and especially a combination of afatinib and cetuximab. MET amplification also was responsible for 5 to 20% of acquired resistance, and there are a lot of MET inhibitors in development. And then there are other resistance mutations that have been found. And then other work showing maybe BRAF mutations, this CRKL amplifications. So
and by the way, that applies to, that resistance applies both to erlotinib and gefitinib.
Oh yeah, I think it's, the resistance mechanisms seem to be the same.
But it may not be the same for afatinib.
Maybe not.
Okay, okay.
So this is work that Leisha Sequis published last year, looking at some of the resistance mechanisms on a large series that they had done of repeat biopsies, showing again that the T790M is about half. They also found this small cell transformation, and so that was very interesting as it came out, and it's been validated now by other groups that there'll be a transformation that occurs, and then those patients tend to do better with the small cell specific chemotherapy. The MET amplification here was about 5%, and then there were a few other mutations that they found. So focusing on the MET, there have been a few trials looking at EGFR TKI plus a MET inhibitor. So the MET-MAB or onartuzumab data looks the most promising right now. They did a randomized phase 2 of 128 patients who started on erlotinib with or without the MET-MAB antibody. And if you looked overall, there was no benefit from the addition of MET-MAB, a negative result. But when they looked just at patients who had high MET expression by immunohistochemistry, there actually was a substantial benefit in those patients for both progression-free and overall survival. So they're now doing a phase 3 trial only in patients who had high immunohistochemistry results for MET. So it's erlotinib plus or minus MET-MAB only in the MET diagnostic positive patients. We're also doing an ongoing chemo trial I'm involved in where patients get chemotherapy plus or minus the MET-MAB, but we're not restricting in that setting just the high MET expressors because we don't know that that interaction is going to be the same with chemo as it is with erlotinib. There's a lot of crosstalk between EGFR and MET. So these are the survival curves, the progression-free on the left and overall on the right for patients who got erlotinib plus or minus the MET-MAB. And you can see a big separation. So we'll see if this holds true in phase 3. And this is a slide just showing that MET diagnostic positive, which is an immunohistochemistry assay, showing the very intense staining and those who seem to have the most benefit from the addition of the drug. Okay, so for EGFR TKIs are active, especially in EGFR mutant non-small cell lung cancer. EGFR mutation testing should be considered prior to first-line therapy, and only EGFR mutant non-small cell lung cancer patients with that should receive first-line EGFR tyrosine kinase inhibitors. Adjuvant therapy with the EGFR TKIs is still experimental, even in those with known mutations. New EGFR TKIs are in development, and MET positive or MET treatment plus an EGFR TKI may delay resistance development in some patients, ongoing studies there. And cetuximab has some activity, perhaps EGFR immunohistochemistry is a good biomarker there. All right, so what about other targets? And that's where there's a ton of research being done. So this was work that Mark Chris presented on behalf of the Lung Cancer Mutation Consortium last year, showing that for all adenos, these are the most common mutations. So EGFR is the second most common. KRAS is actually found in about a quarter of patients with adenocarcinoma. And then EMF for ALK is a little bit less than 10%. And then we have a few that are less frequent, and we're learning more and more about those as we move ahead. And at the time of this presentation, they were finding mutations about half of patients with adenocarcinoma. So talking about KRAS, I just have one slide on it. There are a lot of promising treatment options in clinical trials. We'll hopefully be hearing more about those as we move along. As far as whether or not it's prognostic, the trials to date have kind of gone across the board. So some say yes, patients with KRAS do worse, and some say not really. Some have shown that maybe patients with KRAS mutations don't do as well with chemotherapy. Others have refuted that. So I don't think we really have an answer about whether or not it's prognostic, and we'll hopefully have some trials and drugs that are going to be particularly effective in these patients. We've got the crizotinib story and EML for ALK. So this was, of course, initially discovered just in 2007 by a group of Japanese investigators. And they found that this was a driver mutation in about 4% of patients with lung cancer. This is the break-apart FISH test. It's a little hard to see, but basically the way this assay is done is that they label they have labels to look at this gene, and they should be right up against each other because they're looking at the 5' and 3' ends. However, when there's a translocation, those break apart. And so in the patients who actually have an EML4 ALK translocation, the red and green signals are separated in space versus right next to each other when there's no translocation. So that's what's shown here. And there's a lot of work now being done, as opposed to having to do that FISH assay, which is cumbersome, to move it into immunohistochemistry assays. So there are antibodies being developed to hopefully allow us to do that. And I was just at a conference in Japan, and there, and I think in a lot of Asian countries, they're already doing screening based on immunohistochemistry to then decide who's going to go to those FISH tests. And so I think we'll probably be changing our assays here at some point in the near future. This was also a recent publication that, instead of looking at FISH, was looking at CISH, slightly different technology. You're still looking for that break apart of the signals, but you get to look at the cells a little bit better than you do with FISH. So they've got that component of it as well. So again, I think this is an evolving area where the technology is going to change, but it's still FISH for now. And this is just the reason we need to find these is that patients who have ALK translocations do really, really well with crizotinib and other ALK inhibitors. And the patients who tend to have these ALK translocations, in general, are the never smokers. More of an equality in the male to female ratio, tend to be younger. But again, we're still learning more and more about who has these translocations, because not everyone's been tested yet.
And a number of them have papillary histology,
yes,
which is interesting.
Yeah. Okay, and unfortunately, just like with the EGFR story, we also get resistance. There are a lot of resistance mechanisms. Many of them are similar to EGFR, so you get those secondary mutations that change the binding pocket. ALK amplifications and then KIT amplifications been reported. Some work has been done showing that EGFR mutations can be seen and KRAS mutations. So there's a controversy in the literature right now, but a lot of work being done trying to sort out these resistance mechanisms. So this is one vision of ALK resistance, where you can see that the biggest piece of the pie here is secondary mutations, so changing the binding pocket. You also get ALK amplification, and then they've seen development of other clones, like EGFR clones can come up, or KRAS. But again, this is an area where some groups are seeing it, some aren't, so I'm not sure that we've found the truth yet here. Some other exciting work in the just in 2012, we've had 2 new driver mutations that potentially have drugs that can target them. So one of the ones that's gotten a lot of press is ROS1. And so ROS is very similar to ALK. It's another driver mutation. It's rare. It's only about 1, maybe 2% of non-small cell. It tends to be more adenocarcinoma. Again, it's the younger patients, it's the never smokers. And interestingly, because of its similarity to ALK, there does seem to be crizotinib activity. So a lot of work here, and we're actually looking for this now. I've got a panel of patients who we found ROS, where we found ROS. And this, again, the testing for ROS is very similar to ALK. It's a FISH test, it's a break-apart test. Another new driver found this year is RET. This is also low frequency, maybe 1 to 2% of non-small cell, a little bit more in the adenos. This was a series that was just published showing kind of who some of these patients are. This was 12 patients, tended to be, it was a mix of men and women. They tended to be a little bit younger, but a lot of variability in who these patients are. And this was an analysis that was just published out of China, where they looked at over 600 patients, and they found RET in about 10%, or sorry, 10 total patients out of these 600, 11 total patients, which was much less frequent than ALK, which was about the same as the EGFR in this trial. So I think we don't really know the frequency of some of these yet. I think these kinds of series are helpful, and as we learn more and more, I think we're going to have a better sense of what's the true frequency. And this was just a publication out of Japan showing the same thing. RET was in about 14 of these, about 1% of the patients. ROS was in 10%. ALK was a little, and ALK was a little bit more common than that. Okay, so new genes in 2012. This was another publication in Cell just from this year, where they looked at 183 adenocarcinomas, and they found the genes that we were just talking about, but also some new ones. There's UTAF1, truncating mutations in RBM10. So we don't know the whole story yet, but we're getting closer and closer to understanding it. This was a figure from that Cell publication. And they also talked about other hallmarks, other ideas of what makes a cancer cell, and went into that quite a bit. So talking about sustaining this proliferation of signaling as another mechanism that we hadn't really thought about before. Squamous also has its mutations, and those are being figured out. The Cancer Genome Atlas has done a lot of work, presented at ASCO and now published, where they've identified P53 is incredibly common in squamous tumors, and they've also been identifying others that might be more targetable. There's work looking at FGF especially. This is a figure from their publication that just came out in Nature. Again, looking at these genes, showing that the P53 is the most common, but there are others that might be more targetable. And that's just showing some of the targetable ones. Okay, whoops, skipped one. So this is a more recent review. Again, another pie chart showing what do we know in the adenocarcinoma, what are the drivers, and here we've got the KRAS and the EGFR, ALK, HER2, but adding in the ROS and the RET. And this pie chart is just showing that we actually have targeting drugs for many, many of these mutations with trials ongoing. And again, we'll be hearing more about that in a later presentation today. So this is the NCCN Task Force report on biomarkers in lung cancer. This was a publication looking at biomarkers for many different malignancies. But from these recommendations, EGFR mutations and ALK testing is recommended. And then perhaps KRAS and ERCC1, but with work still to be done there. I just put in a couple slides about how do we look for these. So there are a couple of platforms available to do sort of broad looks for different mutations. So the sequenome assay, the snapshot assay, these are just different ways of doing sort of multiplexed PCR. And one of these publications showed that if you do the snapshot plus a sizing assay, you can find mutant DNA even if it represents a very small amount of the total DNA, even as much as 2%. Okay, so this is a slide showing what we're looking at Stanford. This is our snapshot panel focusing on the EGFR and KRAS, showing that for EGFR we're looking at the L858R and the T790M amongst others. We also look for a lot of other genes, and we're doing ALK testing for ALK fish, ROS fish, looking also for the sizing for EGFR deletions. Okay, so the last topic I want to just mention is sort of an evolving technology, the circulating tumor cells, where there are a lot of different strategies in development. It's not yet standard practice, but I think probably will be, because it's a lot easier to get some blood and look for the tumor cells than to get a biopsy. So this is showing a chip that was developed at MGH. The original chip just had these little basically micropores that stuck out to capture the CTCs, and they were able to capture them and do some testing looking for EGFR mutations in their pivotal work. This is their updated chip, which is more of a herringbone design. There's also work looking at the cell search technology for EpCAM-based immunomagnetic strategy for finding these cells, and there's been some work published looking that the total number of cells might be a prognostic factor for lung cancer, and another study more recently showing that if those CTC levels drop during therapy, that's an indicator of patients who are going to do better. So again, another prognostic factor. This recent publication that came out in Clinical Cancer Research just in the last few months looked at finding CTCs. They were able to find them in the majority of patients on this trial. It was a nerlotinib trial. And they also were able to extract DNA from isolated CTCs and also find circulating tumor DNA in plasma. So really interesting, and I think highlighting the technology and where we're going. So in conclusion, immunohistochemistry is critical to help us determine adeno versus squamous, and that's the TTF1 and the P63, P40. Looking for ERCC1, thymidylate synthase, RRM1, whether it's immunohistochemistry or PCR-based, is still in validation. EGFR mutation testing by PCR or sequencing is standard, and I do that before first-line treatment. ALK and ROS FISH testing is standard. However, there's debate about whether you do it before or after they've had their first-line chemo. There's a lot of newer testing, like immunohistochemistry assays in development. KRAS mutation testing, I tend to do it in my practice because it helps me know what's the likely driver for that patient and perhaps move them towards trials. And then there are many, many others being looked at. I think in the future we're going to be doing next-gen sequencing and really, before a patient starts any treatment, have a much better understanding of what are the genes involved in that particular tumor.
Very good, Heather. I just want to remind the audience that if you have any questions, please send them in. I'm just curious about in your institution, is it an automatic that if you have a patient, that you see a patient and you biopsy the lung malignancy, and they have adenocarcinoma, they automatically get the mutation analysis? So
we're sort of in transition. We're heading in that direction. It doesn't always happen yet. We don't have everything formally in place, but I think that reflex testing is going to be where we are very, very soon. And I know some other institutions are already there. Every patient with lung cancer gets the full panel testing if they're adeno. And whether or not to do that on the squames, as we talked about earlier, is more of a debate.
So we're in the same boat as you are. In other words, not all the pathologists are lung pathologists. We have super subspecialists in prostate, GI, so that the tendency to forget that if you have lung cancer, you have adenocarcinoma, there's a certain amount of mutations we want, including BRAF, because there are studies. I mean, I think if after you hear this talk from Heather, the issue is that if you get these mutations, there are studies ongoing with these various mutations. So it's important to enter patients on those studies. And I think the other issue is what's ready for prime time. Right. We already said that ERCC1 and RMM1 are not yet validated, and the question is when, and should you select your patients. When you see a patient from outside the institution and the biopsies were done outside, do you do the studies in-house, or do you tell the referring hospital to do it and get you the information?
It depends. I think between last week and this week, we've done both. And I'm thinking about some of my new patients. In general, if we can get the block, because we are in-house now doing the snapshot and the FISH testing for the common mutations, we try to get that and do it in-house. If they're in a system where it's not going to work, where they're not going to release that tissue to us, then we at least encourage the referring physician to send the tissue for additional testing, whatever mechanism they have, whether that's in-house, whether that's a commercial entity, and there's several companies that do an excellent job of doing these testing and pretty extensive panels. So, but we do encourage everyone who comes in, especially coming in for another opinion, unless we already know that they have an EGFR or KRAS or ALK, we'd really encourage them to look.
So there's a question on how do you confirm mutations by PCR and KRAS? Is that the way it's done?
Yeah, so the majority of, they're obviously with the PCR you have to know which mutations you're looking for, but it's pretty well worked out for the most common KRAS mutations, and so that's how most of the testing's done. You can of course do full sequencing, but that's a much more expensive test.
And in the patients that you've seen, we haven't seen many ROS1 patients. Okay. And in the patients you've seen, and you started them on crizotinib, had they had the resistance earlier or later, or about the same to the classic patient with the ALK rearrangement?
I haven't seen enough to really answer that. Okay. I mean, I've seen them respond to the crizotinib, but I haven't had enough on it long enough to really get a sense of how long does it take before resistance develops.
So you want to give us a few take-home messages, additional ones for the audience that would be very practical for them?
I think that the main thing is don't let a result come in that just says non-small cell lung cancer, NOS, or not otherwise specified. We really can't accept that as enough to go forward with therapy. So I do encourage to really push the pathologist on trying to get us an answer. Can't always. I've got a case I'm just starting on treatment this week. He's a true adenosquamous. He has P63 and TTF1 in the cells. I mean, they really cannot distinguish which it is. So you're going to get stuck there sometimes, but not too often. I encourage people to really emphasize getting adequate tissue, that a core needle biopsy instead of just an FNA, and trying to get enough tissue to do these tests. Again, in the future, we'll have the CTCs, but we don't yet. I also encourage people to figure out what is going to work in their practice for getting this mutation testing done. And so I think most of us now are comfortable that we should test for EGFR mutations and should have that information before starting first-line EGFR TKI therapy. I've heard a lot of variability in when or if people even test for ALK. And so, again, I would encourage everyone to come up with a strategy for doing that, at least at a minimum, because that's 4 to 7% of our adenos, and there's a drug that really works that you can only get if you know you have it. I personally encourage looking for KRAS because it's the most common, and because even though we don't have treatment yet, we probably will soon, and there are a lot of great trials. So I think in the community practice, we can't say to everybody, you got to test all these genes, because not everyone's going to be able to, and in practicality, it's not going to change treatment for a lot of patients yet, but I think we're almost there.
Well, if you do KRAS first, the other mutations, they're not going to be the other mutations.
Exactly, and so that's where I've heard a lot of different strategies on algorithms. Some places only test KRAS first, and if that's negative, then do EGFR and or ALK. Others do EGFR first, because that's the only thing that's going to change the treatment up front. And if that's positive, they're done, and if it's negative, then they'll think about the others, maybe. The advantage of the reflex testing is you don't have to use as much tissue to get all your answers. Every time you send it back for another test, there's more slicing and less tissue that's left. So, you know, again, I don't think we don't have an answer yet that's going to work for all groups, but people need to step back and figure out what's the right approach to make sure that we're not having patients who don't know everything they need to know about their tumor, because that's going to actually change their treatment now.
So a two-part question: how would you start would you start a patient that had squamous cell carcinoma? And then the other part is, what would you do with a patient with squamous cell carcinoma that had the EGFR mutation?
Well, I mean, the EGFR mutation, I think, trumps everything else. And if it's an EGFR mutation, regardless of histology, they should respond to the EGFR TKIs. Now, should is, you know, not every patient with an EGFR mutation responds, right? 70% response rate. But I would start them with an EGFR TKI and see how they do. If they don't have an EGFR mutation, then I start with a platinum doublet. And, you know, there are arguments for platinum with taxane or platinum with gemcitabine. We're also, you know, there are a lot of trials going on. So we are looking at the METMAB, the onartuzumab, with chemotherapy for patients with squamous histology. There are many other compounds in development also.
Now, I've seen a case with a mixed histology adenosquamous, and they had the mutation.
The EGFR mutation?
The EGFR mutation.
Did you start him on an EGFR
yeah,
TKI? Did they respond?
It just started.
Okay,
but
so we don't know yet.
We don't know yet. And I think that's going to be very interesting to do that. And I think the other issue that becomes important is histology matters. You need big pieces of tissue to be able to get the information you need. And down the road, you're going to see that every patient with cancer that walks in the big institutions are going to be screened for the various mutations, no matter what their cancer is. That becomes important. And I think the other issue then is, even in squamous cell, I think a take-home message is to get the mutations, and especially in never smokers in squamous cell carcinoma.
Absolutely.
So I would like to thank Boehringer and Ingelheim, Genentech, and Daiichi Sankyo for their support of this important education series. Please remember to complete the quiz at the end of this session to secure your CME credits, and stay tuned for our next session: recent advances in lung cancer screening, risk assessment, imaging, and early diagnosis. What is ready for prime time with Peter Bach. My name is David Ettinger, and I'd like to thank you for joining us. Thank you. And thank Heather.